From the Library of Congress in Washington, D.C.
Good afternoon. I'm Ann McLean from the library's Music Division. We're very pleased to be presenting Dr. Alicia Clair in our Music in the Brain series this afternoon, a 2-year project that has been generously supported by the Dana Foundation. Dr. Clair is one of the nation's most distinguished music therapists. She's professor and division director of music education and music therapy at the University of Kansas at Lawrence. A noted scholar and clinician, she also currently serves as the interim associate dean of the University School of Fine Arts. She's a past president of the National Association for Music Therapy and has been recognized with the association's Service Award, Outstanding Professional Contributions Award, and its Lifetime Achievement Award. Dr. Clair is an authority on music therapy for the elderly, highly regarded for her work on music therapy protocols and late-stage dementia. Her book, Therapeutic Uses of Music with Older Adults, is widely used internationally. She has also been a task force member with the Department of Veterans Affairs for the study of transitional rehabilitation and blast injuries. I'd like to acknowledge the strong support of the American Music Therapy Association, which is our partner in this event and in another event in the spring with Dr. DeForia Lane. And especially I'd like to thank its president, Dr. Andrea Farbman. I hope you'll take a moment to look at all of our Music in the Brain lectures, which are now on the Library of Congress dedicated channel on YouTube. Today's lecture will also be on there. And now please welcome Dr. Alicia Clair.
Thank you so much. I'm very pleased to be here today. It is a privilege and an honor, and I was thinking, as I was growing up on a farm in the middle of Kansas, how likely was this to happen? Not very. I think it just goes to the point that we have a heart for music and a heart for life quality, and that's why I'm here, and I want to share things with you today that I hope will be practical and perhaps give you the courage and the confidence to proceed with using music in every way that you can. As we begin, we're going to switch back and forth today between two monitors. I have some video of actual persons with whom I've worked in the past in clinical settings, and then I also have the PowerPoint, so that kind of gives us a reference. And I've been asked to speak today about late-stage dementia, and then with consideration for post-traumatic stress disorder. Now, these two diagnoses are very different from one another, and as we go through, I think we'll find some commonalities in basically how music works, how music functions, and how we can use it for desirable outcomes. One of the things that I've begun to understand as I've worked with the VA Medical Center in Topeka, Kansas for about the last 20 years, and then through my opportunities to work with the Department of Veterans Affairs, is that the World Health Organization brings together the consideration of not looking at diagnosis so much as looking at functional outcomes. And as we look at functions, we do have the opportunity to pull together what similarities we might find between people who have a diagnosis of PTSD and those who have a diagnosis of dementia. So the kinds of things that I find that we have in common with these two populations is the idea of anxiety and fear. And those are typical of many populations as we look at function and functionality in community. Sleep disorders is another issue that's a very serious concern for people who have a multiple diagnosis and various diagnoses. And then we also have problems with community integration. So if we have someone who has difficulty in forming and maintaining relationships, people who have difficulty in engaging in conversations or in social interactions, then we have people who have problems with integration into community. When we think about people who have dementia, and I'm more focused today on the late stages of dementia because they're the most difficult to manage, I believe. We find that community integration may not be what happens in the doors outside in Washington, D.C. or in my hometown, but in the community in which a person lives. As we worked with people who have dementia then, the community becomes the special care unit. And the family members who come to visit are also part of that community. Those of us who spent many hours in professional careers in those settings understand that we never do just treat the person. We really need to work with the family. The family is part of our community, whatever that community happens to be, and that community is going to be defined by the function that's possible with a person in their current state. So I'm not going to try to talk about how we're going to fix problems so much as we're going to manage situations, to use music to contribute to life quality, to make things a bit better, maybe a whole lot better, we hope. So as I bring this to your mind's eye, it's a matter of looking at the ideas of the influence of music on behaviors, and I'm going to have some examples in just a little bit to bring this to your attention. So we have to do sort of the head stuff, and then we'll do the auditory stuff. It's very interesting about music. Music happens in the brain across so many parts of it, and we don't really know how the brain processes music to a great extent. We know that the pleasure centers light up, and we know that the motor centers light up with rhythm. What we understand is that we have physical contributions to that. We'll have psychological, social, and spiritual. And it's hard to talk about it because we talk in linear terms, but when these things are happening, they're happening all at once. So we'll just have to kind of lay out a little bit of the structural theory here so you understand perhaps how to use music yourself a bit better. We know that music can influence heart rate, and there are many old studies, they were done in the 40s, that show that music can slow the heart rate or speed the heart rate. Well, I still rely on those when I'm looking at whether or not I want to help someone be a bit more energized, or I want to help somebody be a little bit more relaxed and less agitated. Blood pressure also shifts. We can increase it or decrease it. We can speed or slow respiration. And that might have a very important consideration if I'm trying to do deep breathing rather than just a clavicular up in the shoulders kind of breathing, which if we have that going on, it doesn't contribute to relaxation. Muscle tension release is also associated with music, and the idea of shifts in agitation and energy levels are all going to be part of the physiology, how the heart is going to respond, how fast it's going to beat in response. The psychological influences of music then come to the opportunities for shifts in vigilance, for people to become either more or less vigilant with music. And the role of a music therapist is always to shape experiences with music to get an outcome that's a not musical outcome. So I might be looking at using music to help somebody be more attentive, or I might be using music to help somebody be less focused and less attentive. It depends on my outcome. Then I will decide what kind of music's best going to facilitate that outcome. Shifts in mood and attitude, mood vectoring becomes a very important part of what we do as music therapists, because if we can shift a mood to a more positive mood, we tend to get better behavioral change. It's an interesting thing to make a statement like that. It seems like it's very pat and very strong, but we do know that if people are not in positive moods, they're not open to learning new things. So if we can shift a mood to more positive and more accepting and more willing and less depressed and less defiant and less, I think, hopeless, hope is a huge thing here, then we can actually facilitate better changes. Emotional release and relief, sometimes with music, and I've done that a lot with drumming with people in late-stage dementia who just cannot speak, and we play out the feelings rather than speak the feelings. Personal expression, all kinds of things happen with music in terms of helping us say what we want to say in unique ways that we can't do verbally. Feelings of comfort and security is that thing about what music you put on when you get home from a day out of the house. Is it music that seems like putting on your house slippers as you sit down with a cup of tea and helps contribute to that feeling of comfort and security and that last deep breath and sigh before you relax into your evening? And the idea of empathic connection. I can connect with people very strongly, all people can, by using the music that's meaningful to them. The social influences of music are very important, and we'll see some examples of that today in video of late-stage dementia. where we can use music to draw people together for a common purpose. We always have music to mark specific events, and Happy Birthday is a song that all music therapy students at the University of Kansas have to play in all singable keys, because you never know when you're going to walk into a group of people and it happens to be their birthday, and we have to sing it and play it because it's the right thing to do. It marks a very special day for that person or persons who are having a birthday. Is anybody having one today? This is a small group. I don't think so. I'm prepared to sing. I hope you are. All right. Points for common experiences. You know, we could talk about the Bob Dylan concert we went to in St. Louis, or we can talk about how we remember the music and what it meant to us and how it hooks us. The integration of generations is very interesting, and you know, I was thinking about this a little bit. Generations have different pop music, and so we don't connect on the pop music so much. We connect on the music that's significant to that part of the country or that ethnic group. And what we find is that in late-stage dementia, just a little aside, people resort to their mother tongue or their first language as they get late in dementia process. They also revert or come back to, rather than revert, I don't think that's a good term, they come back to the music that they learned when they were just tiny. And so they can actually sing it back to you at that point in time. And something will trigger it and they'll just begin to sing. Connections through associations with rituals and celebrations and all the kinds of things that are important to us. We have music, it seems, hooked with every important thing, so that we're going to play some here today too, so that we can mark this as a special event. The spiritual influences of music, I have students frequently who jump to the conclusion that when I talk about spirit, I'm talking about religion. That's not what's meant here. Spirit means breath, spiritual being breath of life. And when we're talking about the breath of life, we're talking about the things that are so important to us that make us human, the things that help make life meaningful and purposeful. It doesn't exclude religious ritual. It doesn't exclude religious music. It includes all music that contributes to this idea of a connection with something outside of the person, a connection with a higher power, something that's not worldly, something that's more released from the time and space of now. So we find that very often people will say, I had a very spiritual experience when I heard that piece of music. I can describe times when I've had very spiritual experiences with people in late-stage dementia who were no longer verbal. One man that I connected with right away at the VA hospital who let me in the door, actually, he was trying to get out. And I came in, and his door was locked from his side, but open from my side. And as I came in, he stared at me with icy blue eyes, and I thought, well, I don't really know what to do here. This is my first day in the unit, and I don't want to have him think that I'm not interested in him by turning away, but these bright blue eyes are a little intimidating. So I decided I would just look into him. And I looked into him, and he looked into me, and I looked into him, and he looked into me. And I don't know how to describe what happened, but we had something that happened that always stayed between the two of us. Because whenever they had problems with Tom, they'd call me. I could get Tom to do anything. And it was very interesting because I would just go to him, and I would touch him on the shoulder or on the hand, and I'd say, Tom, it's time to go to lunch. And he'd get up and take my hand and go. That's the kind of spirituality I'm talking about, but I also did music with him. So I hooked with him in that way as well, I'm certain. Okay, so now we begin to have the opportunity to listen to some examples. Besides having music of our preference and familiarity, which we'll discuss a little bit here, we also have considerations of stimulative and sedative music. And those characteristics are lined out for you here. So I'll just let you look at these. And we're going to have our first example, and we're going to go from sedative to more stimulative. And hopefully these will not be familiar to you, and they will still have the characteristics. So let's hear the first example. So if we were to look at our list here, and we were to look at sedative, that's on the right side, non-percussive, non-syncopated, little or no accented beats. With this, we almost have no meter. It's phrasing and flowing in a way that it's really not even very confined and tied to rhythm or meter in any way. We find that very often soothing kinds of instruments, such as flute in this example, violin, sometimes guitar, depends on how it's played, cello perhaps, and these are tending to be instrumentations that are more flowing and are less percussive in nature, piano being more percussive, obviously. Let's go to the second example. So obviously we're using guitar there, but it's more percussive. There's some syncopation. Does everybody understand syncopation? It's when you expect the beat to happen, but it doesn't quite. So it actually functions to facilitate toe tapping, essentially. And this is a little bit of a toe tapper, but not as much of a toe tapper as this next selection. And our final selection with this set. Thank you. I can't ever resist putting in a little Zydeco. I don't know why. It's just fun music. So what we have here are examples that are just kind of put together in a way to help us understand a progression. It's called a progressive STEM program, where I would select as a practitioner, as a music therapist, or you as a person who's interested, could go from something slower to more fast to pick up the speed. Now, the point here is that it's very difficult to just come into a situation and put somebody in a high tempo music if they are fairly lethargic and having a hard time moving around. So the idea is an old music therapy idea about how you start where the person is in their activity level and maybe even in their emotional level, and you move them in a direction that's desirable. Now, if I had somebody I wanted to calm down, I would go the opposite way. Years ago, I worked with adolescents in psychiatric programming in St. Louis. It was a very interesting job. I decided when I left it, I was about 27 years old, and I was almost too old at that point to have that job because it takes a lot of energy and a lot of physical strength, basically, to work with young people who lose control of their behaviors, and you have opportunities then where you have to help them settle down. I use music a lot. If I wanted them to settle, I would just match where they were and take them down. So it's really an opportunity to understand that this is very powerful. We don't really know quite how it works, except that listening to music puts a dampening on the autonomic nervous system. So there's going to be a relaxation and a quieting that occurs. If we want to speed somebody up, we're pumping the blood a little faster. We can get people to move a little bit more. And essentially, if I have somebody who's really dragging, I'll try to encourage them to tap their toe, to physically interact, and then maybe pat their hands on their thighs, and then we'll maybe stand up to take a walk. So it's not just a matter of rushing into somebody's room and say, "Maud, it's time to get your walk. Come on, we're going to put your shoes on, get up, let's go." That's not going to be nearly as successful as moving into that process of getting her to take a walk. She's likely to resist any effort to get her up unless I move her into it. What's fun with these four examples, and I do this when I have time, and for the sake of time, we're not going to do it today, but I usually will have people take their pulse rate before the first piece. Then we'll play it for a minute and a half, and we'll take the pulse rate again, and I'll have them rank the music from dislike to like. And after we're through with those 4 examples, I'll ask everybody in the audience how many had their pulse rate change, and everybody raises their hand. And then I'll say to them, how many of you got faster? And about half of them raised their hand. How many of you got slower? About half of them raised their hand. So it's a very interesting thing to understand how this works. It gets to the paradoxical effects, and this is why we can't play music over the loudspeaker system in nursing homes and get people to do what they want, what the administrator wants them to do. I get calls like that all the time. What kind of music can I play in my home so I can keep people calm? What kind of music can I play in my home to get people to walk more? What kind of music can I play in my home to keep people from being agitated? It's because what might be relaxing and quieting to one might not be to the other. Years ago, I did a study in the Alzheimer's unit at the VA where we went in 3 times a day and played music to see if we could affect agitation. And we got no change, no matter what music we played. And I think it was because of this. I explain it this way. So when we do consider using music for someone, especially if we're going to use it for a therapeutic outcome, and that's an outcome that's a non-musical outcome, we will tend to look very carefully at the music preference, and then we'll test a little bit. And we'll make sure that it's going to be effective. And if it doesn't work, we go to something else. We understand the principles, but if the principles aren't working, it's because we've got associations that are hanging over things that are giving us trouble in our programming. But we do know that we have very powerful tool in music. And it's available to everyone. It truly is. So that you have an opportunity to understand a little bit more about it today. I'm going to ask you if you would just start playing selection 9 right now, because we're going to illustrate a point here about music's power. And it takes a little while to get started. It's interesting. I used to do workshops for the Benedictine sisters in Atchison, Kansas. Now, they are a monastery, and they don't get out much. And I played this, and nobody knew what it was. Except they did tell me, that sounds like scary music. So what we understand is that we have certain conventions in music, and the way music is worked together, you know, with that dissonance and with those loud sounds and with that driving rhythm underneath. Even if you can't see that fin of that shark in your mind's eye and your visualization that you're getting, you still know that that's a bad thing. Okay, the point I'm trying to make here is that associations happen with music, and maybe the best jump off here is to talk about the dog salivating when the food is presented, and then pretty soon the food is paired with the bell ring. Everybody got this in general psych class. This may be the first class, the first semester, if you went to college. And then the food is removed and the bell rings and the dog still salivates. Well, the whole thing about this Jaws music is that shark and that fin and that music. One of my students pointed out to me that it's not classical conditioning because it doesn't involve food. It's really operant conditioning. But the point here is that we have a stronger impact with the experience because we have an auditory association with it. And that auditory association happens for a very, very long time. I'm going to ask you to skip and go to number 10, which is not on your sheet back there, but thank you anyway. And are you getting visuals? Okay, what are they? The ocean, the ship, being in the bow of the ship, the scarf blowing back, the pose over the bow of the boat. Okay. Well, when we have these kinds of connections with music, then they'll last forever. I mean, whenever you hear that piece of music, you know, I can't hear Theme from a Summer Place without smelling Aqua Velva shaving cream. Because that was a piece that was played at all the high school dances, and my boyfriend wore Aqua Velva. So everybody's laughing because we all have those kinds of connections. I don't think they even make Aqua Velva anymore. It's pretty disgusting. I hope they don't. But the point is that if I heard that piece of music, I could still remember the feel of his cheek, and I could still remember, you know, kind of the juxtaposition of how he used to hold me when we danced. And it's a very pleasant memory. It's a very good thing. But some people will have very bad things associated with that too. One time when I was getting ready to do this work with dancing and spouses, I had a lady who said to me, let me think about it. I don't know if I really want to do that. And I said, okay. And we can just assume, you know, if your husband has late-stage dementia and you'd really want to have a connection with him, that you might want to dance with him if it was possible. And I'll show you some dancing in a little bit. She said, you know, I'm going to say no. She said, when I married him, I had a daughter who was 6, and my husband had died, and I really needed to be married. I didn't have an education, I didn't have a skill, and I needed a home for my daughter. And she said, he started beating on me the moment I entered the house, and she said, the real irony in it is now I have to take care of him. She said, I don't want to get that close to him if I don't have to. Years and years. So what we find is that the associations with music, the associations with things, activities that happen with music like dancing, may not be a good thing. And the important thing is to understand everybody is different, everybody is unique. Okay. We talked a little bit about culture and how the mother tongue comes back. I want to illustrate that we also have generation differences when we look at music from different generations. And so if you would play number 7 first here.
Blue moon, you saw me standing alone without a dream in my heart, without a love of my...
Thank heaven for Ella Fitzgerald. That was the music that was playing with my parents' generation, and this is the version that I danced to. Let's have number 8.
Bomb 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 dang 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 ding it on ding blue moon 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 blue moon dip 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 moon.
You're giving yourself away. Some of you are singing along. Thank you. Same song. Unbelievable, right? And I wondered why my parents said, "Why are you listening to that noise?" And everybody understands that. What might be relaxing for someone like me is to go back to the doo-wop songs and to listen to those. Even though they tend to be a little bit of a toe tapper, I feel very comfortable there. It was a very safe time in my life, a very pleasant time in my life. I have students who tell me that they listen to heavy metal to relax. Okay, I couldn't do it, but they do. And then we end up writing rap songs when we're doing clinicals at the Juvenile Detention Center because that's the kind of music that really works with those students there. So we find that we fit the music to the person, and our own musical taste as practitioners never enters into it. We have to listen to our own music at home. All right. So as we talked a little bit about how we could put together some of the functions with persons who have dementia or persons who have PTSD, all of these principles would be in common with what I would try to do to shift moods or to shift activity levels or to try to work on sleep. Now, sleep is a very important consideration because many of us have problems with that. And I think that probably one of the most important things is to have an adequate sleep hygiene. Many people will drink coffee all day to keep themselves awake and keep themselves stimulated, to the point that when they finally get the phone call from the family member that's talking about all the tragic things that have happened in their life for the day, they'll lie down in bed about 11:30 and expect to drop off right away. And it just can't happen. So sleep hygiene is a matter of looking at the caffeine intake and typically stopping by noon, because caffeine has a very long half-life and will keep you awake at night if you drink it in the afternoon. Also, the matter of looking at some of these ideas with stimulative and sedative music and understanding that it needs to, your activity level needs to tone down, and using music to do it could be very important as part of that process. As the day unwinds and gets slower, then the lights need to get less intense and the stimulation in the environment gets less intense. And everybody knows not to call me after 9 o'clock, especially if it's family, because they just crank me up, I'm telling you. And so we look at the possibility then of associating relaxation techniques in managing stress and preparing for sleep. And we might go to music that's very, very atypical, something we've never heard before. It's brand new. So I'd like you to listen to, for just a moment, let's do the Sleep 8 so that you're ready with the blue. It's in the blue. Yes. No. The Sleep 8 album. That's okay. While he's getting that ready, I didn't give him much warning. What we know is that if we have associations, that can keep us awake even if the music's quiet. So we want to go to a music that's manufactured if we can, especially for sleep. And that's what we have here. Thank you. You're fine. Now, I don't expect anybody here to be sleeping because you haven't been associating any relaxation with this music. So I would go back to that conditioning model and I would say, okay, we would use this music, and with it we would practice some deep breaths. We would practice some progressive muscle relaxation, or another technique where we could just let the muscle tension release. And as we were doing the breathing and the muscle tension release, we would get to a situation where we were relaxed. And hopefully the idea that it should lead to sleep is that you empty the mind of all the things that are buzzing around in there and get to a state of quiet. And most people who use music like this will say, you know, as long as I use the music, I don't even have to use the relaxation techniques anymore. All I can do is put the music on, and I automatically start to let go. So it's a matter of whether it's this music or another piece of music. It's a matter of finding something that seems to lead you or help you or support you through physical relaxation and letting go of the day for sleep. Now, those people who go to sleep all right and wake up in the middle of the night, that's a tough one. We can do a thing called self-regulation where we say, okay, it's probably not a good idea to get stimulated again. So one of the things, the first thing I would suggest trying is to go through this little bit of a ritual again where you put the music back on, you start doing the relaxation again, and very often by just emptying the mind of all the thoughts of the day, drift off again. There are just some times, though, when sleep won't come, and all of the sleep experts say, well, then get out of bed and don't stay there and watch TV and eat pizza and do all the things that are very wakeful. But stress management and sleep management are two very tough things with dementia care, with caregivers of dementia care, and also people who have PTSD because they have the nightmares and the flashbacks, which are very, very, very difficult to manage. Okay, so sleep hygiene, using music, conditioning, relaxation with the music, and using it exclusively for sleep. And very often these especially composed pieces of music will have on them, do not listen while driving. Because if you do condition yourself to relax, you actually can drop off. Another thing that's very helpful is to do a little technique called a jaw drop, where you just release the hinges of the jaws and let the tongue spread. And try to imagine or think about opening the throat and relaxing the muscles. And if you do that, it's really conducive to relaxing the whole body. It was a technique developed by nurses really for pain management. And what it does is it relaxes the muscle tension. I do it driving the car sometimes. You can do it any place. Just relax, let the hinge drop, let the tongue spread, and open the throat, get the shoulders relaxed. Little techniques through our day that help us not get caught up in the frenzy of what tends to make us sick, which can be stress, as we know. Now, one of the points for managing stress in people who have dementia is that they can't tell you they're distressed, but they will show you. They will get agitated, they'll pace, they'll throw things, they may get verbally abusive, they may get physically aggressive, and basically what they're trying to tell you is, I'm in a situation and I can't handle it, and I need some help. So one of the things that happens with them is that if we can approach them one step at a time, don't rush at them like we talked about a little while ago, and to really use music to set the tone in the environment. If they're supposed to be getting a little bit more quiet, to use music that's quieting, and to give it a little chance to work. Don't just put on a Sousa march and expect that they're going to get up and get ready to take a walk with you. So it's this idea of moving from the place where people are physically and emotionally to where they need to be for the next task. I have a slide here about procedural memory because we find that people who have late-stage dementia can do many tasks that they're very used to doing: brushing their teeth, dressing, eating, combing their hair, washing their face. All of these kinds of things are much easier because they're so automatic if the person is not in some form of distress. Even going to the toilet, making sure that they know where it is, helping them find it. There are all kinds of interesting pieces of information where people can't find the bathroom because everything is white, and they can't see the toilet there because it's white and the wall's white, and they can't tell the background from the foreground. So just all kinds of little visual markers, but at the same time making sure that we don't get them in such a stew by trying to hurry them around that we've got them upset, because they can engage in procedural memory if they're not stressed, far more likely than if they are distressed. And also, not just the procedural memory, but you'll get much better behaviors in terms of cooperation. The nurses on the unit used to tell me that they would always do all of their medical testing after we'd been there. They could take blood pressures, and they could do medication administration or even give injections, and they'd always wait till music therapy had been there because the persons were so much easier to work with. And I think it's just because they had been relaxed and they had been doing something meaningful to them in some level, and that the nurses came up and said, I need to take your temp, and okay, fine, stick the thing in the ear and we're good. When I first went on the unit, I'll never forget this. One day I saw this nurse walking, pacing with his patient, and looked like she was holding his hand. I got a little closer. She was clipping his fingernails because he couldn't sit down for her to do it. So I thought, you know, if I could have been there a little ahead of time, we might have been able to at least have him hold still while she clipped. We're just about ready to go to our examples with the dementia care, and I have to tell you that a lot of these clips have been around for a while because I've been doing this work for 25 years. And I never ever show these videos without telling you that these are the angels that help make things better for other people because they let me videotape and then let me try things with them, sometimes for the first time it was ever tried. And as a result of that, they have been very generous by letting you see them and be a part of their life for just a little while. We're going to start with an early middle stage dementia. And the dynamics as you get into dementia differ. When there's an initial diagnosis, there's a great deal of depression and agonizing because as people learn more about the disease process, there can be a great deal of loss associated. By the time we get to this point, we're really concerned about function. So I have, for a while, been studying through clinical work how people actually behave in these different stages. So what I have for you is their usual unmusical behavior and then their musical behavior so that you can see what kinds of things happen with them. For instance, in this early middle stage, and I call it this arbitrarily, it depends on who you read how the staging goes. And so I'd rather work with function and behaviors because that's more meaningful to me, and it will be to you too. So this person has day-to-day conversation intact, and the long-term memory is really good. Advanced ADLs are not functional. Advanced ADLs, activities of daily living, are things like managing the checkbook and paying the bills. Planning meals sometimes can be very troublesome. So this person is somebody who could probably make a cheese sandwich if they'd always made a cheese sandwich and not have problems with it. Activities of daily living are appropriate, which means the person can dress themselves, and they look pretty good. They know which clothes to kind of put together because they have used these sweaters and pants and shirts together for a while. They can tend to be depressed because they understand clearly that they're still losing a lot of function, and they feel helpless, and there's a lot of family anxiety. What is going to happen when we get further in this disease process and we can no longer stay at home? The musical characteristics are very interesting because if the music is something in their background and they played it a long time ago, they can still do it. They may use notation as a cue, but they're not really necessarily reading music anymore. It's just kind of there in front of them. It's kind of a prop that's feeling comfortable to them. But they don't read new music. They may have once, but they've lost the ability to read. They can play well in ensembles and even insert riffs. I've got an example for you here. Sings familiar songs with no problem at all, but does not easily learn new songs, even if they have a familiar structure. The people I'm going to show you are people who have played guitar for a while, but when I brought in a new piece in the same key and in the same country western style, it couldn't be done, even though I was playing support on piano. So it's just interesting to note this. Now, if a person doesn't have a musical background and they're at this stage, they can still sing familiar songs. And what we find very interesting, and one of my wives was very generous to say to me one day, "Honey, you know that song Embraceable You's a lovely tune, but we don't know the words, and you'd do better if you would go to Home on the Range." She was right. She taught me that little piece of information. So songs from the youth, religious songs, if people have sung religious songs. These people can always entrain with rhythm, and you can say, well, they've never played a musical instrument in their life. I'm going to stake my life on the fact that if you handed them a mallet, they'd take it in the dominant hand, and if you handed them a drum, they'd take it in the other hand, and they would automatically make rhythm. So it's just there. And it's nothing that has to be trained in. These people can also dance, exercise, and move to music. I had one session right here, the first blue mark in the experimental, where I cued and taught the people what to do, just like in this session. And then by the time the second session rolled around, they were doing it themselves. The important thing here is that music therapists will sometimes go in, I have seen this happen, I've done it myself, and do a research project and find wonderful things and then just leave. What I was trying to do here was to bring something to people that they could use after I left. And so I didn't necessarily use instrumental accompaniment, I didn't use guitar, I didn't use piano. I wanted them to use recordings or just their voice in order to facilitate interactions. What I did at the end then, we have a return to baseline where we weren't using music. And what we know is that the music opportunities yielded a great deal of engagement. And as the people got more experienced with it, the better it got. So I think it was very productive. My last question to people as I left was, do you feel like you can do this without me? And 100% of them, all 28 of them said, yes, we think we can do it without you. So that was important to me, that they could do something with music with a care receiver who was likely their family member or a close friend. Okay, we're going later in the stages now. And what we find is that we have conventional responses. Hi, hello, hi, how are you? Fine. Beautiful morning, yes. That kind of conventional response is there. Little spontaneous conversation. Severe confusion. Needs assistance with basic ADLs, which means we have to help dress. We really need to help bathe. Requires supervision for safety. This is the point at which family members start having a great deal of stress because they can't trust the person to not leave the house in the middle of the night or to not turn on the stove and leave it burning. Because I did that myself the other day. Got in some trouble. Musical characteristics and musical background. They can play familiar music generally by rote. Again, we're not reading music here. And anybody who passes out song sheets, that's not really helpful. They just get them up in their face and rattle them around a lot. We just need to get their faces up and get rid of all the props because they're not meaningful anymore. If they do use music notation, it's just because it's there. It's a prop. Can't read unfamiliar simple music, sings familiar songs. Entrains with rhythm. Entrainment's a very important thing for us to understand today. If we take anything away, it's the idea of entrainment, and I'm going to illustrate it for you a little bit later. Dances, exercises, and moves to music. Now, if they have a non-musical background, they can still do a lot. They can still sing those rote songs, they can still entrain with rhythm, and they can still dance and move to music. Now, it was kind of interesting. We got the larger engagement with singing, and that didn't surprise me too much. I thought we'd have higher engagement with dancing, but there's a reason for that. They just don't have the stamina. They can't stand long enough to dance. So adaptations have to be made. What we also find, this chart just shows one of the things that we were interested in looking at is whether or not we get initiated responses from care receivers, and we did. One example is the woman who's playing her husband's drum. I mean, she initiated interactions with him using music, where most of the time she was there and he would come and talk to her and she could not reciprocate. So it's a way when we use music to have the opportunity for interaction. It doesn't just come one-sided from the caregiver, and that's very important, I think. And they will tell you that it is. Part of the reason why we can do rhythm or that we can do drumming is because of entrainment. And the entrainment is very, very significant in the outcomes of whether or not people can stay on their feet or still do physical exercise. So let's hear that first example. We have some special music that we've done that Blues 40 is what? There it goes. This is 40 beats a minute. He was a little faster than that, but not much. That's not a stable tempo, but very often with stroke rehab, that's where we start, is around 40 beats a minute. There's still a lot of one-limb stance, and the reason why that's significant is with a stroke, they tend to want to stand on their strong side. So they'll quick swing that other side, and that's why you get the limp. But we want to work ultimately in a stroke to this next tempo, which is 110. Which is a... With him, I didn't have the benefit of this kind of music. I would have today, maybe it's good that it's 1995. Today what I would do is I would set him up in a program, pacing him at a safe cadence, which would probably be around 60 for him. And I'd just make sure that the nurses had the music when they walked him to the dining hall. He just took a walk that was 80 meters down the hall and 80 meters back down the hall. That's a huge distance. He can do very good endurance with that kind of a walk. But they're not feeling like he's safe to be on his feet. With a rhythm, he is. Now, we followed that up with the explanation. It comes out of the Physical Law of Entrainment with a Dutch scientist very early in the 1660s who said that nature is very, very efficient, that it takes less energy to pulse two bodies together in a rhythm than in opposition. So the idea is we find his cadence and we match it as closely as we can, but he will come into the cadence we provide simply because he won't be able to resist it. And as a result of that, we can actually shape his motor responses through stimulating auditorily the motor center of the brain. It's really fascinating. There's a lot of lab science that backs this up from the Center of Biomedical Research in Music at Colorado State University. And I've given you this 2 clocks placed close together will tick in synchrony. That's a very interesting thing if you go into a clock shop, to notice how the clocks are working together. And if one stops, they will be out of synchrony when it starts, and then pretty soon it'll go into synchrony with the other clocks. Kind of spooky, but very interesting. It's that idea of the law of nature that the synchrony is easier than the opposition. So, you know, if you're taking a walk with somebody, their pace is a little faster than yours, you'll probably match them, or vice versa. Okay, you all know about what immobility leads to. Prognosis for falls, and it's very bad if we don't have mobility. We have falls. If we have falls, we tend to have deaths within the first year after a fall, a very serious fall. And once a person has a fall, they very often don't recover to the premorbid state. So that means that they don't ever get as good as they were. And that's very difficult. It leads to debilitating conditions. One thing goes to another, goes to another. And so the best thing to do is to avoid it. One of the things is to walk people and have them participate in exercise programs. So we decided that we would do a lot of walking in the VA with entrainment, and we also designed an exercise program to work with that as well. We wanted to make sure we had balance and flexibility, because anytime somebody has to put on clothing or put on, shoes, socks, you hopefully are not going to be standing on one foot. I've been trying that myself lately. It's tricky. You know, I might be at the age where I need to sit down when I do that, but I hate to give up, you know. I wanted to show you this. This is interesting, I think. RAS, rhythmic auditory stimulation. I actually tried, after this gentleman, to do this with a lady in an Alzheimer's home. It was a home for dementia care, specifically Alzheimer's. The yellow shows you the time without beats from her chair to the dining room. The red shows you the time with beats from her chair to the dining room. She could get there so much faster. Well, what was happening was we could organize her stride and her cadence so that she was safer and more mobile. So I know there's something here. But then I took this into a special care facility. Marjorie Okonski and I walked lots and lots of people. And what happened was we had them so debilitated that they needed an assistant to walk. And we found no significant difference with music, no music, clicks or no clicks. And I think the reason why is that we had some people on 2-person assist. And when you get 2 people on either side of a person and they start to walk, there's a swaying that goes on. It's kind of a hip-to-hip thing. So I think what we have here is an artifact of assistance. What the staff told me was that it seemed like the person was less of a burden. Of course, that was speculation, and you can say, well, they were just expecting differences because we were doing music there. So I'd really like to kind of explore this further, because I think that if we work with people who aren't as far along in the disease process, more like the gentleman you saw, I would really like to see if we can affect the ambulation. I've seen it in this video. I'm pretty sure we can do it. But if we let them get much farther than that, we can't really predict it, because we have to have too much assistance for them to be safe. Okay. So exercise for strength and flexibility, we went to all kinds of pains in our VA to make sure that we developed a program that would be a very good program. The problem with it is it's not published anywhere, but there's a little bit of research here. Went to a nursing home in Michigan, and what you see in the yellow is the exercise program with music, and what you see in the red is the engagement in the exercise program without music. Well, it's kind of a no-brainer. If you put music on, people are more likely to exercise. But we need to do this again and get more detail, because what I think is happening also is that it's not a matter of adherence. I mean, they're adhering better with music, but I think they're also going to do range of motion better. I think we're going to get better repetitions. I think we're going to get better everything in the exercise program. So that's on my list of to-dos, along with many of these other things that we've been talking about today. And I already have a nursing home facility lined up, and we're starting in January. So we're on the way. Okay, going to late dementia. Ambulation is gradually lost, and the person is too large of a fall risk. And then they get to the point where they can't manage their motor process. Psychomotor abilities are lost, may be vocal but not verbal, requires assistance in all ADLs. Everything has to be helped with, and may require gastrointestinal implantation. And this is a really tough deal because families are heartbroken. They don't know whether they should or whether they shouldn't, and they will often ask anybody what they would do. And my answer to that is always, it's not my parent, it's not my husband. I can't tell you what I would do. I don't know. I think it's very, very, very hard. So we give a lot of empathy. Sometimes they will go ahead and do an implant and sometimes not, but the person begins to not eat. Incontinent of urine and stools, and so things are very difficult, but this person will still respond to music. This person will turn his or her head, move the body, open eyes, shift from agitation to calm, and shift from calm to agitation in response to music. And this is a little bit of the outcome. I spent quite a bit of one summer. You can see it was a long time ago. This was published in 1996, but I don't know if anybody's done anything with this since, where I sat beside people's beds or their chairs, the reclining chairs, and I sang to them for 2 minutes. I sat with them for 2 minutes, and I read to them for 2 minutes. And I did this in a randomized way for 28 people. And what I found was that people responded to the singing and the reading very readily. And there was not a statistically significant difference between singing and reading. And I was really kind of glad there weren't any differences there, because people, if they don't feel like they can sing, can read the newspaper or read poetry or read a book or read anything. It's the rhythm of the voice, it's the sound of the voice of the person that's familiar, and it's readily available to anybody who can read. There was a statistically difference between just sitting with them and either reading or singing. So I'm very encouraged by this because I think it's another thing that family caregivers can do when they go to visit in late stage. And it's an important part of being a part of what's happening. Just to kind of give us a recap here, we use music therapy to enhance functional outcomes. With this, we're trying to promote engagement and adherence. It's all about life quality in palliative care at this point. We're going to stimulate arousal and interest, whatever interest means, but very often people will engage very spontaneously. All they need is a little entry and sometimes prompting, or probably more important, the best structure that you can have to allow them to participate. Rhythm is a good structure. Familiar music is a good structure. We can bring together the caregiver and the care receiver in very positive ways. And I think for most important outcomes probably is reports I get from people that says it gives me a chance to get close again. The gentleman that I told you about, who was the one who met me at the door my first time on the unit, I ended up being close to his wife because she would come from western Kansas to visit, and she told me lots of interesting stories, but one of them was that when her husband was not even diagnosed yet, this was at a time when we really didn't understand this disease very well. She said she was sitting in her living room one day, and he comes out and he's got his shirt on and his bolo tie and his cowboy boots, but he's got on no pants. And she says, "Tom, where are you going?" He says, "I'm going to town." And she says to him, "Well, if you're going to town, you probably ought to put on some pants." And she was dealing with this by herself at home. And things were as good as she could make them. The kids are all grown up and gone. So she's there. She's running a little grocery store, and the town is familiar with the problem a bit. And she said, the night that the neighbor came in with Tom and said, "Lois, you've got to do something. I just found Tom in my basement messing with my hot water heater." Well, nobody locked their doors there, which was a problem too. But the townspeople would always bring Tom home. It just got to the point where that was not going to be possible. This lady still lives in western Kansas. She's a lovely, 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 lovely person. And I cherish her to the depths of me because she was a great teacher and she allowed her husband to be part of my life too. On the last time I saw him, he had pneumonia, and I went over to the medical center to see him. And I went in the door, and he had the sheet pulled up over his head. And I said, Tom, Tom, sheets pulled up over his head. And he's not looking, and she's sitting in the chair beside the bed, and she's saying, pull the sheet down. Sheet's still up. And I just started singing to him, and pretty soon the sheet's down like this, and then it's down like this, and then he's got the sheet down. And she says to me, I really wish that he would respond to me like that. And I would say to her, he will. All you have to do is sing. And she would say, but I don't feel like I've got a nice voice. Oh. So I'd say, it doesn't matter because he's the voice, or you're the voice that he loves. You're the voice that's always here for him. So she said to me, all right. I said, you're clear down here at the end of the hall. None of the nurses come down here unless they need to do something. You know kind of when they're going to do that, so just have a high old time. So she said, well, I'll see. So it was shortly after that I got a notice that Tom had died, and I was totally shocked. I had no idea that he was going to die. I mean, we thought he had pneumonia and he'd recover and he'd be back in the unit, like always. And I looked all over. She wasn't anywhere around. She'd already left town, and I got her at home. And she said, I want to thank you for the gift you gave me. And I said, what? She said, I started singing to Tom. She said, my last memory of him was looking at me while I sang to him Rock of Ages. And she said, he was there with me, and he was connected with me. I just want to let you know, thank you. Well, it was a very powerful thing. And so what I tell students and what I tell people when I train in facilities is that our job is to bring the opportunities and then get out of the way. So as we look at emotional intimacy and how important that is to people, to connect people from their relationships of long ago, to restore anything that we can, or at least keep it intact as long as we can, that it's going to contribute to personal identity and dignity, and it's going to really add to life quality in everyone concerned. And it's a real high for those of us who get the chance and the opportunity and the privilege to work with it. So I thank you for your attention today. We have a few minutes for questions if you have them. Yes?
Where do we get the music specifically?
That's an interesting question. There's a lot of music available. What I played for you today is called Sleep 8. It is Liquid Minds is the website. Chuck Wilde is the composer. That particular CD I like a lot, but other people, it's classified as New Age. Actually, didn't he just get named number 1 on the chart for New Age music, and that's the album. It's fabulous, I think, but it's because I've used it to sleep quite a bit, and I've given it as gift to people, and they say they can't get they can't get through the first cut. They're out. And if you noticed, it really moves, and then it slows down, and it really entrains you to deep breaths, and it's fabulous. But there are other great pieces of music too, because I'm not selling anyone's music. I think the very best thing to do is to go through your own personal library and see if there's something there that works. And it can be anything.
So you don't mean that some scientific something decided that brain waves mean something and they can hear some.
No, I think we've gone through the understanding of entrainment. We've gone through the understanding of breathing. We've gone through the understanding of muscle relaxation. We've gone through the understanding of clearing the mind, and we've gone to the point of knowing that we can condition a response and that it's really going to be a matter of practice, and it's not going to happen instantly. Perhaps for some people it does, but not for everybody. I think if anybody's telling you they can train your brain waves and they can do all kinds of things by making a recording that they mass produce and sell on the market, I would say be cautious. I don't know that they can do that. I don't know that the science is there yet. So, if you understand the things about the behavioral responses and the relaxation responses, and understanding that the autonomic nervous system will dampen, which means that flight-fight response is going to quiet down, and the stress is going to quiet down if you let it, unless you feed it with, oh my gosh, I've got all these things to do tomorrow. I wonder if I'm going to get it all done. I need to get up about 5 o'clock. You know, that kind of thinking you do at night. That won't help you. I had somebody who told me one time, they said, well, my kid's having a real hard time sleeping, and I wonder if you can help me with that. I said, well, describe what goes on. She says, well, he goes to bed and leaves TV on. I said, that's it. I said, what happens with light, we have to get really in dark space for the melatonin to work. I mean, the melatonin has to happen. It only happens in the dark. It doesn't happen with the blare and the glint and the click of the TV light. So I said, try getting him to turn his television off. Well, he won't do it. I said, well then, he must not want to sleep. So it's a matter of some choices. Sometimes they're hard. Okay, yes?
I want to go back to the very beginning. You mentioned the music about calm and not so calm. But what about, you mentioned focused, and you can play music for being focused. Would you give some comments on that?
Some people find it very helpful to use music to focus attention, and when we're working with I'm not exactly sure where to go here. If we're going to train attention, we're going to look at focusing attention first and then sustaining attention and developing the alternating attention. And the way I would do that is I would probably start with a musical experience. One thing I like to use is drumming because everybody can do it, even if you don't have a musical background. So I might just start with having people just do a basic beat, and that would sustain their attention.
What if they're not that bad off? They're just trying to be focused.
You know, it's a mixed thing. About half of the people that I talk to over the last 36 years tell me that they have to use music to shut out background noise in order to work in a cognitive framework, to learn, to study. Then about half of the people say that it interferes. For me, I'm one that interferes. So I can't use music when I'm working because I get too distracted. So the focus of attention really is, again, individualized, and the type of music to use would be individualized. What I would guess to say is if you wanted to help your attention focus, you'd want to put something that masked background noise, and it might be something that had very little variation in it, because you wouldn't want a lot of novelty. If it has novelty, such as syncopation, or if it changes and has dynamic changes, then it's going to cause problems with shifting attention back and forth. You don't want it to draw attention to itself. So if you're going to use music that is going to help you focus your attention, you're going to want something that just kind of mellows out the background and fades out some of the intrusion. Therefore, it has to be very non-intrusive. And I can't answer that question for you. It'll be a matter of listening to several different types. Yeah, I would not do anything with dynamic changes or anything that was very rhythmic.
That you played, what was that?
It was called Over the Sea to Sky, and I think it's James Galway. Mm-hmm. Yes?
What about patients in the nursing home who are on chemical restraints?
So if they're getting drug therapy, Zyprexa or whatever, can you get through to them? And
Yes.
Get them off the drugs? Or
Well, I don't know about getting off the drugs. I will use Bob as an example. When he came to us, he was totally snowed. He was almost to the point of drooling. He was non-responsive. And the first thing we did was to get him in a really good schedule, predictable schedule. And we got him off the drugs as soon as we could. You know, you have to be responsible about that, and it has to be done with a physician's advice about the dosages with a withdrawal and all the things that can happen with that. And Bob was impossible to manage in a non-structured environment. He'd been at another facility, and they had to, what we call, use the chemical restraints to manage his behaviors. We got him off all medications within the first 3 months he was with us. But I have a funny story about that. One day I went on the unit, and Bob was sitting in a chair with a seatbelt on. And he was messing with his shoe. It was a slip-on shoe, and it fell off. And he couldn't get it back on. So he unbuttoned his seatbelt, and he got out, and he put it back on. He got back in the chair, and he buckled up his seatbelt. And I said to the nurse, I said, what's going on with him? And they said, well, you know, he's got this background of being a salesman, and he has been getting too close to some of the other patients. I mean, he'll get real close proximity, and then they get defensive because he's violated their personal boundaries, and he's been getting smacked in the face, and we cannot have that. So we said, Bob, you just got to stay away from people. Well, that didn't work because he was a salesman for years. He knew everybody in the state of Nebraska and probably some in Kansas. And so what they said to him was, Bob, you need to sit down, you need to strap yourself in, you need to buckle your seatbelt, and you need to stay there unless there's a reason to get up. And they did that with him for a little while. It wasn't a restraint. He could unbuckle it anytime he wanted to. And that was a real good transition for him. And then when he got through not needing to do that, he was kind of in our culture and fine. We never did restrain him. He wasn't on any medications when you saw him there that I know of. He might have been on heart medication, but it wasn't a restraining medication. Okay. Sure.
When you how did you decide when you were doing your therapy and you were developing your technique, how did you decide to sing to the people yourself versus playing recordings of people singing to do the same thing?
I'm really glad you asked me that. Because, first of all, I wanted to make sure other people could do it. But, and then you get those situations where you've got a problem that's brewing, you can tell it's brewing. One time I had a patient who was just screaming in the hallway, and I got with, distance enough that he couldn't hit me. And I started singing back to him in the same key. He was screaming. So he was doing, ah! And I'm going, ah! 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 And pretty soon he's looking at me. And he's singing back to me. Singing is somehow, and I don't know the answer to this, but there's something very intimate in singing that connects us together. And it might be all those lullabies in the rocking chair, if we got any of those at all. I think there's something very intimate about that connection. And anybody who's singing to you is not going to hurt you. Singing is used for comfort. It's used for the remediation of pain or hurt or sadness. We're rocked and we're sung to. And now I tell spouses, family members, get in bed, wrap your arms around them and sing to them, if you can't do anything else. And they don't want to sing because they don't think they have nice voices. So I don't know. We'll get through that. But I think singing is somehow very powerful as a human mechanism, as a human voice we carry with us. It's our own instrument. So somehow it really is, I don't know, it's very, very important and essential. That's maybe not a very good answer, but that's all I know at this point in time. It's the best I can do today. Maybe we'll know more soon. Okay?
You had that intense eye contact. When you were singing to them, you had that eye contact and that touch, which a recording wouldn't have.
That's right.
So how do you tease out the component that's that and the just having the attention versus the music?
Well, I know how you'd put that in a research design, where you would just have somebody who made eye contact and maybe spoke to them, and then you'd have people making eye contact and singing to them, and you'd have somebody just standing there. It's something that I think you could do to see if singing was essential. It's that humanness again. I think it's that connection. I just know that it's very typical to get a response if you sing to somebody. Now, the other thing happens is really interesting. I one time did a little work with oncology with some of the nurses at the VA, and I was over in the treatment rooms from time to time, and one of the nurses, the head nurse, sat me down one day and she said, we have to have a talk. And I thought, oh my, what have I done? And she says, you've been coming over here singing. And I said, yeah. Is it a problem? She says, well, the speech therapists in the next room find it interfering with their work because you're disturbing them. And they asked me to talk to you. And then she said, also what's happening is one of the patients is a little uncomfortable because he thinks he's supposed to do something back, and he doesn't know what to do back. So I think that when we get to the dementia stages, but how do you read discomfort? I've not noticed discomfort. I've not noticed problems. What I've noticed is they don't leave me, and they could. They don't push away from me, and they could. They don't strike out with me, and they can. So I think what you do is you read the body language in terms of the response. And if they do any of those things, then you need to shut up and move away. It's not maybe for everybody. Okay.
Actually, I have 2 questions. What happened to the crying lady after you left the facility? Did she revert?
I'm sure she did.
Okay.
She had no family. That's the hard part. You know, I think we have to somehow put in people's minds that volunteerism is something really important. I didn't have anybody to leave her with. I looked around, I checked. They said sometimes volunteers will go to her, but you know, volunteers will sometimes only go to those folks who are most receptive of them. They won't want to be around somebody who's not as receptive. So I don't know what happened to her. I've wondered about her a lot.
The other question is, do male therapists who do what you do have the same success rate as women?
It was interesting. I worked at the VA with 2 male music therapists, and they did. And it was interesting when one of us would be successful with somebody, maybe the other one wasn't. We got so that we were able to identify which people would respond more strongly to either of the 3 of us. And the ones that got the most response from a particular person was the one that was assigned to that person, so that we could really assure that we were getting the very best outcome possible. But I really spent more time in the Alzheimer's dementia care secure unit than either of them. We worked rehab together later, and it was more significant there. Sometimes people would prefer a male to a female. But you know, I don't know, if you're doing the right things and reading the right signals and trying to follow with getting connected and letting the person know non-verbally that you care about them and you're there to spend a little time with them, I don't know that it matters. It might, but I don't know. I would think not.
How do you know which song to sing to somebody?
Okay, this is how I do it. I go to the person's age. I figure out I know how old they are. And I go to, now I go Google, and I find out which songs were popular when they were between the ages of 18 and 20, or 22. And those are the songs I choose. So, You Are My Sunshines from the 40s. A bunch of these songs are from the 40s. These people were World War II veterans for the most part, Korean veteran, a couple. So that's how I decide. And then if I'm going to do something that I want to trigger for rote, I go to, in the military hospital, all of the military songs, the Army, the Navy, the Coast Guard, the Air Force. You learn those first and foremost, and you just know them. And then I go to the patriotic songs. And always Kate Smith, Irving Berlin, God Bless America, always, for everybody. Then things like Home on the Range, My Darling Clementine, songs the kids don't know anymore. I'm very concerned, and I've talked with my music education colleagues about this, I'm very concerned about music education right now, because if we don't have things in common, when we get older, there'll be nothing to tap. I mean, I'm tapping residual memories is what I'm doing. And if there's nothing in there, I got nothing to go to. So I'm a great proponent of music education for lots of reasons, but that's one of the reasons, because as we get older, we need to have some common things that we share that we can actually be community in some way. When we lose all of our other faculties, we can be community in music. Yes?
I have a question regarding a younger person, like a 25 years old, who has a PSTD and has nightmares and stuff like that. And he listens to music that none of us would agree that it's relaxing. Does it matter what kind of music person listens?
No, if they're relaxing, it's right, spot on. When I used to work with children, though, I was very discouraging of certain music that was provocative. Alice Cooper, some of you don't know about Alice Cooper, but this person used to do concerts where he'd kill chickens on the stage and squirt blood in the audience. And the kids were very anxious about all that, and they'd like to listen to Alice Cooper music. And I think it's because it scared them so badly and they couldn't really cope with it. I just said, no Alice Cooper music in my clinic. So I think there are reasons why there might be some music. If you know the music sets someone off, this person is of an age that they're going to decide what they want to do with the music. But I think what has to happen is that you can try to educate a little bit and say, you know, you're probably having some nightmares that could be connected to what you're listening to before you go to sleep. It might be good if we could do a little switch and see if we can do something a little different and see if it has any effect. And if it does, it'll be a good thing. And if it doesn't, we're back where we were. I mean, it's a more complex question that you're asking than that, but that's basically what I would suggest at this time. The individualization is very important.
Yeah, I found your comment very interesting when you said that the patients actually can hear even though they seem like they're dead. My son was in a coma and doctors thought he was in coma, but he could hear them talking.
Of course.
And taking the saw and cutting his leg off.
Yes. Yes.
And he remembers everything.
Yes. And he couldn't respond and he couldn't tell him.
No.
That's horrifying to me. Horrifying. He may need some pretty good work to get through that process. That's pretty traumatic.
We need it. My question was also about PTSD and just what types of research studies you have done on PTSD or that you are familiar with in non-gerontology population.
Well, it's very interesting because we didn't even know the term PTSD with a gerontology population that we have now. It was called shell shock. And then PTSD in the 1980s came through the VA as a specialized area of treatment. We had a unit at the Topeka VA where I was, but I did not work on it. So I have to confess that my knowledge of PTSD is very limited. I know it can be very debilitating. The flashbacks and the nightmares are horrifying, and they can be set off by sights and smells. Yep. Yes. I think what you want to do is to use music that entrains different behaviors or conditions different behaviors. I think you'll want to switch the music so you don't get the flashbacks. You've got to go to something comfortable, and what you're going to try to do is cancel out the detrimental effects by having positive effects. And it may not work. It's not rocket science, but it is terribly difficult to manage.
You know, I think we might just have time for one more because I think Dr. Clair has to zoom out and take a plane.
I do. It's time to go back with my ruby slippers to Kansas. Oops, I'm sorry about
Anybody
this.
have a final question? Yeah.
The changes in behaviors will happen instantaneously. They'll happen right. If it's right, it's right, and it's right, and it's going to stay right. However, the length of sessions depends on how long someone can attend. People can get physically tired. We've had people playing large table drums with large mallets, and they'll switch mallets from one side to the other, and they'll beat and beat and beat. And finally, and I think they're probably angry and frustrated and can't get it said, so they beat it out. And when they're done, they'll just lay the mallet down and sit back in the chair because they've had enough. Or they may just leave you. You can tell that they've had all they can tolerate because if they can, they'll move away from you. If they can't move away from you, they'll turn their head away from you and they'll give you signals. You have to pay attention. I tell students, I don't know how to train you to do this, but you got to listen with your ears, guys and gals, and you got to listen with your heart. You got to feel it and hear it and know it. You just can't, you have to be sensitive. They don't give strong signals. So you have to really be attentive. And there's no good answer to that question. But you should, if you're doing the right thing, you should see response right away.
This has just been a fabulous session. Really, thank you
you
so much.
This has been a presentation of the Library of Congress. Visit us at loc.gov.